Hello, everybody. My name is Marla Neufeld. I'm a surrogacy attorney at Greenspoon Marder. Welcome to the surrogacy space. Today, I have with me the very wonderful Dr. Jenna McCarthy, a board-certified reproductive endocrinologist with IVF MD. She and I work together often with a lot of our patients. I think she's wonderful. She's such a great resource for anything third-party assisted reproductive related and anything fertility related medically. And I just want to say, first of all, welcome to the show, Dr. McCarthy.
Awesome. Thank you so much for having me. I'm excited to be here.
Thank you so much. Well, first, I just wanted to start off so our listeners can just learn a little bit about your background, where you went to medical school, and how you got involved and interested in doing reproductive endocrinology.
So as you mentioned, I'm a board certified reproductive endocrinologist, which for listeners who don't necessarily know what that means in addition to medical school and 4 years of OBGYN training, we do an additional 3 years of fellowship in reproductive endocrinology. And then we take a national board exam, which requires both written and oral examinations. Not everyone is board certified, but it's certainly something that I'm very proud of. I did my training at the University of Michigan, which is one of the top medical schools for women's health. I did my medical school, my residency, and my fellowship all in that one place. And I became interested in REI actually when I was looking at medical school. I was fortunate to be a part of a program that was looking at a whole bunch of different careers in the health professions. And so in organizing, I helped organize the class, and in organizing the class, we brought in physicians, we brought in physical therapists, we brought in optometrists and ophthalmologists, kinesiologists, just so that we could kind of let people see that you don't have to necessarily be a doctor to be in the health professions, because there's a lot of really wonderful professions out there. And the doc that we had who came in was a reproductive endocrinologist. And when she was talking about her experiences with her patients and what she was doing, just a light went off inside me. I was like, this is what I want to do. And so that was before I ever set foot in med school. And pretty much from the time that I started as a first-year medical student, I was volunteering in one of the couples clinics in the REI department. And, kind of initially it started out as a shadowing position. And then they, as my training progressed, I was able to take interviews with patients. And it was just wonderful to be able to be involved with it from the very beginning.
Oh, that's so cool. It's something you helped organize and at the same time enlightened you to what you do now professionally. That's really cool.
Yeah.
And so I know that IVF MD has offices all over the state of Florida, but which locations do you work from and see patients from?
So I am based exclusively out of the Jupiter office, which means that I see patients here, although my patients can monitor at any of the different offices. And thanks to the availability of telehealth these days, I actually have patients all over the state of Florida.
That's awesome. Yeah, so that leads me to what we work together on most is third-party assisted reproduction. I'd say the majority of your patients and my clients that we work on together are working with a surrogate, possibly egg donor, different genetic material. So I'd love to talk about your role, because before anybody gets to me and starting a legal agreement, they have to go to you and get medical approval. So I just wanted to talk about what that medical screening looks like, first for the surrogate, and then we also can touch upon the screening for the parent or the intended parents.
Sure. So if we have someone who comes in and is planning on using a gestational carrier, usually what the first thing we do is once they've identified the person that they potentially want to be their carrier, whether that's working with an agency, or if it happens to be, if they're fortunate enough that they have a friend or family member who has offered to carry for them, typically the first thing we do is we review the patient's medical history on paper. So the ideal candidate for a gestational carrier is someone who has carried a pregnancy successfully before. I actually think that that's an important part of the puzzle, not just because we know that they're able to carry a pregnancy successfully, but also because it usually means that they have children at home. They know what it's like to have a baby. Just makes it a little bit of a smoother transition. So we ask them to send us their obstetrical records. We ask them to fill out a personal and family history form, so we can just kind of take a look and see if there are any red flags that would make us say, hey, I'm not sure that this person is a good carrier.
And that's actually a question that I get a lot. Just 2 points that people ask me is age and BMI. Are those hard and fast? Is there wiggle room on that?
So the ASRM guidelines recommend that we not use gestational carriers past the age of 45.
Okay.
The reason for that is the advanced maternal age can increase both the woman and the baby's risk associated with pregnancy. So that's not to say that women can't have successful pregnancies over the age of 45, but if a friend, a family member, or an agency donor is carrying a pregnancy for you, you want to make sure that both your carrier and your baby are going to be as healthy as possible.
Right. Understood.
Yeah.
Okay. And how about the BMI? Does that play
Yeah,
into?
so there are associations between BMI and increased pregnancy complications in particular. And it's a trend. It's not, a specific cutoff. It's not, one of those situations where if your BMI is this, then everything's
Okay.
fine. And then as soon as it goes up above this, nothing is fine. It's more of a gradual increase in risks as BMI increases. But we do have to set cutoffs somewhere.
Okay.
Each individual facility or IVF center will have their own BMI cutoff, but most of us would prefer that a gestational carrier not fall into the obese range, which is a BMI over 30.
Okay. Okay. So once you get the records and you do kind of like an initial evaluation, what does the surrogate do next as far as the medical screening typically?
Yeah, so once they've passed that sort of initial records review, we typically ask them to either come in and have blood drawn, or if they don't live locally, to have blood drawn someplace close to them. And we also arrange for them to come in to do a saline infusion sonogram. Now, the blood draw is to look for, things that we might need to optimize as they're getting ready to go through a carrier journey, making sure that their thyroid is optimized, making sure that they don't have any signs of insulin resistance, making sure they're not anemic, and that their vitamin D levels are good. Might be some examples of things that we do. The saline infusion sonogram is a test for us to make sure that there's nothing inside the uterus and there's nothing about the uterus structurally that would decrease the chance of success with a subsequent pregnancy. Things that we look for would be uterine anomalies, so birth defects of the uterus, polyps or fibroids. Those are correctable things typically. C-section scar, isthmus seal. So if you've had a prior C-section and it didn't heal particularly well on the inside, you wouldn't necessarily know that until you go to try to have another pregnancy. So we're looking for all of that.
Okay. Well, it sounds like a very thorough evaluation.
We try, because what we don't want to have happen is if a carrier is going to not meet the standards that we're looking for, basically be disqualified, we would prefer that be earlier on. And that's why we do the records review first. And that's why we do kind of some of the very, like nitty gritty screening from the very beginning, so that we don't end up with, intended parents having gone through the psychological evaluation with their gestational carrier, building that trust, building that relationship, creating the ground rules, meeting with you and coming up with a contract, and then have us say, hey, this isn't going to work.
And that's why I think it's important that we don't start legal until you fully evaluated. So I think it's just like to follow the steps, I think, is really important for everybody.
Yeah, it is a long process. And so it can be frustrating because a lot of our patients, as you know, are like us. They're type A personalities, and we tend to do many paths at once. And so to our brains, it's like, okay, well, why can't we do the psychological evaluation and the medical screening and the legal all at the same time? Because that's going to save us a lot of time. In this particular situation, I do think that there's a benefit to doing them in series as opposed to in parallel.
Right. Absolutely.
Yeah.
And then as far as like the other evaluations that occur for the intended parent or intended parents, what's typically involved in screening or approving them to proceed with a surrogate?
So for the intended parents, we're screening them as if they were going through IVF themselves, because they are. We're simply, the embryo transfer is the last part of the puzzle that's happening where there is a change. Because we're using a gestational carrier, we do have to do a couple of steps to meet FDA requirements for use of a carrier. So the FDA considers using a carrier or using an egg donor or using a sperm donor, as a tissue transplant. And so we take our patients through the exact same screening that they would go through if they were, for example, donating a kidney to a family member. What that involves is blood work to look for infectious diseases like HIV, hepatitis, And they actually have to be, the preliminary ones can be run in any laboratory, but the final ones actually have to be run in a lab that is dictated by the FDA. There's very special labs that they can use.
Wow.
We do, yeah. So it's sometimes patients are like, wait, I just did this a couple of months ago. Why am I doing it again? And it's because the screening labs are done in a lab that's convenient and inexpensive. And then when we're like, yep, everything looks ready to go, we do that final checkpoint where we do it with through the FDA.
Oh, interesting. Oh,
Yeah.
I didn't know. That's very cool.
Yep. And then they do come in for a donor physical exam because they're acting as an egg donor or a sperm donor for the gestational carrier. That physical exam is head to toe, and we're basically looking for, some type of infectious disease. If you think about it from the perspective of most organ donation is people who basically are donating their organs after death, they can't give a history. So when the FDA rules were created, it made sense that there was this intense physical exam that was done to look for anything that might put the future recipient at risk. And also recipients of tissue transplants are frequently immunosuppressed. And so you really have to be careful about those types of diseases. Thankfully, that's carried over to the gestational carriers because you want to make sure that we're keeping those carriers safe as well.
Absolutely.
Head to toe exam. And they also fill out a questionnaire, and that questionnaire is standard because it is issued from the FDA and it asks so many questions that as you're going through, you're like, really?
Wow.
But every one of them actually has a purpose. And depending on the answers to them, we can help, figure out, is this going to be a problem or is this something we simply need to disclose?
Oh, very interesting. I mean, it's certainly thorough. And, as you know, in Florida, we have a unique section of our surrogacy law that has a medical need requirement for the intended parents that they have difficulty gestating to pregnancy, or there's a risk to the fetus or the mother. And a little bit stems from ASRM guidelines of some form of medical need. So I was just curious, as a physician, what are types of things you see as to why an intended parent, what's an indication of needing to work with a gestational surrogate?
There's typically two main causes in my experience. The first is that the woman is experiencing recurrent pregnancy loss. And then the second would be that she has a medical disorder. Now, there's an entirely different group, which would be patients who don't have a uterus. So gay couples, for example, or a woman who's had a prior hysterectomy but wants to have a baby. Those two groups are obviously going to need to use a gestational carrier as well.
Right. Yeah, and I've also seen, I guess it ties into the first reason, like if someone's going through cancer treatment and they're taking certain medications, that could be risky. I mean, we see the gamut of why somebody might need to work with a surrogate.
We really do. Yeah. And it's such a gift that these gestational carriers provide for their intended parents. And it's, I'm always in awe.
Yeah, it's really amazing.
Who are willing to take that leap of faith, and the gestational carriers who take it with them. It's pretty awesome.
And who needs to be tested? Like if a couple's married or partnered, for both the surrogate and the parents, is there a set rule for that?
Yes, the ASRM guidelines and the FDA guidelines say that basically you could almost think of it as anybody whose tissue is going to touch. So, for example, if we take a heterosis couple, it's going to be the woman and her partner are both going to need to be screened because they're providing the eggs and the sperm, and then the carrier needs to be screened because she's going to be receiving. If the gestational carrier has a partner, that partner doesn't necessarily need to be screened.
Okay, got it.
Does participate in the psychological consultation, and that's an important piece of the puzzle, but sometimes people don't understand why we are asking them to do that. But what it really is, and I know you've spoken with Dr. Golden recently, so she would have gone into this in even more detail, but really it's respecting the fact that when someone is acting as a gestational carrier, everything that's a part of their life is impacting that pregnancy journey. And we want to make sure that it's a safe and supported pregnancy journey. And so making sure that they have that support at home with the person that they're living with is really important.
Yeah, and I'm so glad I spoke with Dr. Golden about how in Florida, it's not a legal requirement to have a psychological evaluation. So we look to the doctors and the clinics to be the gatekeeper to that requirement. So I'm so glad to hear, you see the importance of it. I think it's invaluable to the whole process and a step that should never be skipped. So
Yeah, I agree 100%. One of the things that I talk with patients about is that psychological consultation is really an opportunity to set the groundwork for the relationship. And if there are things that are really important to the couple or really important to the gestational carrier, getting that out in the beginning can really make the entire process so much smoother. You don't
Yeah,
want to find out midway through that you guys are on different pages.
absolutely. And it's great that you do so much third-party work because you can issue spot. Like I know your patients that call me said, "Oh, we talked to Dr. McCarthy about this, so we thought it would be a good idea to reach out." And I know you're not a lawyer, but you know enough to know what to mention, which I think is really helpful.
Yeah.
And that also goes,
Something
I
that
know
I'm
this
really
is,
passionate about. You know, I really,
yeah, and it's not even surrogacy. I mean, even like all the way to like when there's same-sex female couples having a child together, you know, you've raised the issue of like, should they have a step-parent adoptions? You really are always thinking about what they might need like across the board for the whole process.
yeah, I mean, you don't want someone to have a baby and then, have something happen that we could have predicted ahead of time. If we could have
Right,
protected them, in my case, medically, in your case, legally, obviously we want to do that. We want to treat the whole person and not just the one issue in front of us.
right, right.
Yeah.
And when an intended parent is thinking of proceeding with a surrogate, I know you touched upon this a little bit, but what are some things that they should be thinking about that you're going to be looking for in approving her?
In terms of selecting a gestational carrier. So I usually encourage people to go to the ASRM website, which is
Okay,
asrm.org, because
okay,
it lays out pretty clearly what we should be looking for when we're looking for a gestational carrier. Basically, the ideal situation, as I mentioned before, is a woman who's already carried a pregnancy successfully. But there are a couple restrictions. You would normally think more is better. So if she's had more pregnancies, it must be a better thing. But that's
mm,
not always true. And so if you have a woman who has had three or more cesarean deliveries, we are concerned that she's going to be at increased risk of pregnancy-related complications. Or if
okay,
you have a woman who has simply had 5 or more pregnancies, vaginal deliveries or otherwise, then we're concerned about increased risk as well.
hmm,
We mentioned the age already. We kind of mentioned the BMI. We want to make sure that they don't have any significant health issues themselves.
okay,
Um, and and so it's really nice to have this document where you can look and just kind of see all the boxes that I'm mentally checking as I'm looking at your carrier, because it does. I recognize that it's difficult for patients as they're going through to say, well, is this a good carrier? And kind of as I alluded to before, you don't want to build this relationship with somebody and then find out that they're not going to be the person that you're going to be working with. And so to be able to kind of self-assess the information that you have is really
right.
helpful.
And what point do you stop seeing the parties? Like, let's say they've, evaluated, done the transfer. How long are you typically treating the surrogate till she's graduated to the OB?
Assuming that it's convenient for the carrier to come in and that she's not, in Tallahassee or something like that.
Yeah.
Typically, we keep them till about 10 weeks along. So that's
Okay.
6 weeks past their pregnancy test, or about 8 weeks from the time of their transfer, just to kind of like back it up a little bit for people's mental math.
Yeah.
Reason we do that is that we're, at least in this office, and I think in most centers these days, we're keeping carriers on hormones till about 10 weeks along in pregnancy. That's
Okay.
the point where the pregnancy has taken over. In an unassisted pregnancy, the pregnancy has taken over from the ovary in terms of hormone production to protect the pregnancy. And so when we're talking about an assisted pregnancy, or in particular a gestational carrier pregnancy, we want to make sure that we've gotten through that period of time so the pregnancy
Okay.
can protect itself before we stop the hormones. So we
Right.
like to keep the people till they're about ready to come off the hormones, and then we're good.
Okay. And then is there further communication with the OB, or at that point, does the OB generally just kind of take over with their own protocol?
We're always available to the OB, but most of the time at that point, I tell them, guess what? You now have a normal pregnancy. You get to be a
Yeah.
normal pregnant lady. You don't have to do all this extra crazy stuff. And that, I think, for many of the carriers is a relief, because most of these women had no difficulty conceiving on their own. And so
Mm.
this is something that's new and different for them, and having to use medications and take injections and get all these ultrasounds and stuff feels a little bit difficult or unusual. And so to be able
And,
to go back to something that's so comfortable, I think is really a good thing for them.
and I presume there's a lot of training and nurse assistants to these women who have never maybe done injections and
Oh yeah.
um, yeah,
Yeah. Although the internet has been our best friend in that, because patients literally can just look up videos now. So, they go through it with the nurses, but then, they went through with the nurse and now it's a few days later or even a couple of weeks later, maybe. And it's, 7 a.m. They're supposed to be taking their injection and they're like, uh-oh. And they just click on the link that we sent them and it's a
that's so
video
cool.
again. They can review it. They can do it at the same time and mirror it. It's been really helpful actually to have something.
That's so helpful. Yeah, because being on the phone is different than actually watching somebody do it. That's a great resource.
Yep.
And as far as like resources leads to my next question, I know that you have co-authored different books and publications about various fertility related topics, like ovarian reserve, fibroids, fertility preservation. I was just curious kind of if you're still working on these different publications or where patients can find some of these great resources that you've studied.
Yeah, so I think the ability to look at the literature can be important for some patients, just depending on their background and how much of a deep dive they want to take. And the internet, of course, is always a dodgy place.
Yes.
It's great information there, but you can also really go down a rabbit hole and end up not at all where you thought you were going to be.
Yes.
So I typically recommend starting with the ASRM website. I think that that's a really wonderful website. The information that's there is going to be reliable. It's vetted by the American Society for Reproductive Medicine. And then different depending on different situations, we'll sometimes say to patients, here, go to this website or go to the, check this out. And give them more guided information.
Awesome.
Yeah.
And I know as a social media follower that IVFMD has really cool videos. I've seen you speak and other physicians at the practice giving great little tidbits as well. So that I think that's a great resource also.
Thank you. That's funny because that is the most uncomfortable part of my entire job.
I get that.
I am not the person who can make those videos. I just feel really, really.
Dr. Wood has really mastered the.
She is amazing, isn't she?
Yeah.
And Dr. Pomerola, same thing. Like they are fun when it comes to
they're
being
funny.
They're
they're very entertaining.
Yeah.
And so to my last question, not least, what is the best way for patients to reach out to you in your practice at the Jupiter location?
So for the practice, they can just call the main IVFMD number, or they could go to our website, www.ivfmd.com. And then, I am on Instagram, and then as Jupiter Fertility Doc. Certainly, I'm happy to answer any questions that patients might have in terms of that. But if they're more like, I know I want to do this, and I just kind of want to make an appointment, reaching out to us through the website is usually the fastest way to do it.
And if somebody's just considering surrogacy, they're not sure yet, like, is it okay for them to reach out for just like an information kind of info gathering?
Absolutely. Yeah. Over the years, I've done a number of, like initial consults where we talk about what the process looks like. And also sometimes where I'm talking with patients who know that they're going to use a carrier, but aren't there yet. They're saying, hey, we know that this is going to be a couple of years down the road, but we also know it's a long process. What can we do now so that we can shorten the process when we're actually ready?
And you mentioned telehealth. So if an intended parent or parents don't live in Florida, we see patients from all over the world. You can meet with them at least in certain capacities, virtually as well.
Yes, absolutely.
Awesome.
Yeah.
I'm good. That's so cool how that's opened up, to allow more communication all over the world like this.
Yep. It's been really great. Actually, it's one of the few good things that came out of COVID.
Right. Exactly. Well, I know we could talk forever about this whole process, the medical screening and all the really wonderful work you do to help your patients. Your work is just, you have babies come into your office because of your help, which I think is just so amazing. And thank you so much for your time and expertise and sharing it with us today. And we'll be happy to share your website and your Instagram handle and everything in the show notes so that everyone can reach out to you.
Awesome. Thank you so much, Marla. I appreciate it.
Yes, thank you for coming today.